Good morning or good evening, everyone, depending on where you are. Thank you for joining us for the second session of the 2021 ISPD Virtual Education Series. My name is Yair Blumenfeld, and I will be moderating today's webinar, which is focused on abdominal wall defects. First, we will hear from Dr. Mary Norton, followed by Dr. April Adams. Before we get started, I have a few announcements to share. If you need technical assistance, please use the chat function for support. Throughout the presentation, you can submit questions for the presenters in the Q&A function. We will address these at the end of the session. You can use the thumbs up button to vote for the questions you like the most, which will push them up higher in the question list. You may also choose to raise your hand to ask a question, and the moderator may call on you. This event is being recorded. If you do not wish to be recorded, do not raise your hand to speak or submit a question to the Q&A. I will now introduce our speakers. Our first speaker today is Dr. Mary Norton. Dr. Mary Norton is a perinatologist and clinical geneticist and is a professor in the Department of Obstetrics and Gynecology and Reproductive Sciences at the University of California, San Francisco. She's the Director of Maternal Fetal Medicine, Vice Chair of Clinical and Translational Genetics, and Co-Director of the UCSF Center for Maternal Fetal Precision Medicine. Her clinical and research interests include genetic testing and its application to prenatal screening and diagnosis. She focuses on the unique aspects of translating new genetic and genomic technologies into improved care for pregnant women and their fetuses. Much of her current research involves use of genomic sequencing in the setting of fetal anomalies. Our second speaker will be Dr. April Adams. Dr. Adams is currently an assistant professor at Baylor College of Medicine in the departments of Molecular and Human Genetics and OBGYN Division of Maternal Fetal Medicine. She completed her residency training in obstetrics and gynecology at the University of Minnesota and fellowship training in both maternal fetal medicine at the MedStar Washington Hospital Center and in medical genetics at the NIH. She specializes in high-risk obstetric care and reproductive genetics. Her research interests include health disparities in the implementation of prenatal genetics, the impact of aneuploidy on placental development, and genetic etiologies of late-term stillbirth. We will now watch the presentation from Dr. Norton, followed by Dr. Adams.
Hello, and thank you to the International Society of Prenatal Diagnosis for organizing this great webinar series. My talk today is on the genetics of abdominal wall defects, which is an interesting topic about which we still have a great deal to learn. I have no disclosures that are relevant to this presentation. So the major and more common types of ventral wall defects include omphalocele and gastroschisis, which everyone on this call, I'm sure, is familiar with. There are also more complex ventral wall defects that include syndromes or sequences that are different anomalies seen together more commonly than expected by chance. These include the OEIS sequence, which includes omphalocele, cloacal exstrophy, imperforate anus, and spine abnormalities, pentalogy of Cantrell, and limb-body wall complex or body stalk anomaly. Amniotic band sequence can also result in disruption of the ventral wall as well, although I'm not really going to talk about amniotic band sequence in this talk. Cloacal and bladder exstrophy are also ventral wall defects that can be seen as part of the OEIS spectrum. And again, there is significant overlap of these complex disorders, and I'll talk about those more later. There's somewhat of a lack of consensus regarding precise diagnosis of this category of defects and how they overlap or differ from each other. But again, I'll talk about that a bit more later. So gastroschisis and omphalocele can both be diagnosed by ultrasound at 11 to 14 weeks gestation. You can see them here in these 3D images, and they can have a somewhat similar appearance, but beyond that, they are really different disorders in ways that are quite interesting. So the ventral wall develops by folding of the embryo at 3 to 4 weeks of development, and the bowel is initially present in the base of the umbilical cord. This is important, obviously, for sonographers and sonologists to be aware of, as before 12 or 13 weeks of gestation, there is a normal physiologic finding of a bit of small bowel in the base of the umbilical cord that resolves after 18 weeks and is no longer able to be seen as a normal finding. So omphalocele occurs when there is failure of this bowel to return to the abdomen, and it can involve the small bowel as well as potentially other abdominal organs. And here is what an omphalocele looks like in the infant at birth. Because it is in the base of the umbilical cord, you can see that it is covered by this membrane, which is amnion and Wharton's jelly on top of the protruded abdominal organs. As is seen with many anomalies, the prevalence of omphalocele is more common actually during pregnancy than it is at birth. And this is due to the high in utero lethality of aneuploidy, which is highly associated with omphalocele. One really important characteristic of an omphalocele is very highly associated with other abnormalities, aneuploidies, and syndromes. And although omphaloceles can do quite well when they're isolated, as we'll hear about in the latter part of this talk, they are rarely, in fact, isolated. More than half have associated anomalies. About a third will have aneuploidy, particularly trisomy 18, and many are associated with a clinically recognized syndrome. When omphaloceles do have other anomalies that are associated, aneuploidy is more likely. And interestingly and importantly, trisomy 18 in particular is more likely with a smaller omphalocele lesion. Again, the associations most common with omphalocele include aneuploidy, particularly trisomy 18, as well as Beckwith syndrome, which I'll talk about a fair amount, pentalogy of Cantrell, and again, OEIS sequence. There are many, many other syndromes that have also been associated with omphalocele, although these are less common with fewer reported cases. So again, omphalocele is highly associated with other structural anomalies in many organ systems, particularly cardiovascular abnormalities, which are reported in as many as half. So while trisomy 18 is the most common genetic disorder associated with omphalocele, Beckwith syndrome is probably next. And this is particularly true once aneuploidy has been excluded and in isolated cases in which there are not other structural abnormalities. It's been reported that Beckwith syndrome occurs in as many as a third after exclusion of aneuploidy. And again, Beckwith is more common with isolated cases and in IVF pregnancies. Again, I'll talk a little bit more about that later. And in some reports, as many as 20% were conceived by ART. So Beckwith cases typically include only small bowel, and usually there are not other structural anomalies, but many have features of overgrowth, macrosomia, organomegaly, macroglossia, polyhydramnios, and placentomegaly. And in one recent study, only about a third of cases are diagnosed prenatally. So it is important to think about Beckwith syndrome once aneuploidy has been ruled out when you make a diagnosis of an omphalocele. So this is a case we saw actually a number of years ago of a 32-year-old G1P0 who we saw at 32 weeks of gestation. And she had features of overgrowth, although not, interestingly, an omphalocele. So this was a fetus with a very large protuberant abdomen, which you can see, likely due to hepatomegaly. There is a large, easily visualized pancreas, significant macroglossia, which was really quite impressive. And then this is a kidney, which is 6.5 centimeters, which is much larger than it should be at 32 weeks of gestation. And looking at the biometry, the abdominal circumference is off the chart, greater than 40-week size at 32 weeks gestation. The fetus was greater than the 90th percentile, 3,800 grams, again at 32 weeks, and there was polyhydramnios. So classic for Beckwith syndrome, although as often happens with just genetic disorders, didn't have the omphalocele, which often prompts us to do testing. So Beckwith syndrome, this patient went on to have molecular studies done on the amniotic fluid. We were very suspicious and confirmed hypomethylation of the imprinting center 2, IC2, which is one of the imprinting centers that are associated with Beckwith syndrome. And we confirmed that diagnosis, although this baby had very, very striking features after birth, and that diagnosis could certainly be made clinically. So the genetic causes of Beckwith syndrome are quite interesting, and there are various genetic and epigenetic alterations that involve growth regulatory genes on chromosome 11. And the most common molecular mechanisms are loss of methylation on the maternally inherited chromosome at imprinting center 2, and this is responsible for about 50%. Paternal UPD for chromosome 11 causes 20%. Gain of methylation on the maternally inherited chromosome at imprinting center 1, and pathologic variants in this CDKN1C gene, some of which are inherited and some are de novo, and then microdeletions or duplications that disrupt these genes, and karyotype abnormalities can also alter the relative dosage. So the genetics and the genetic testing are somewhat complicated, but karyotype and or microarray methylation testing and potentially sequencing are all important to make a diagnosis, although it has been reported that in about 20% of clinically diagnosed cases after birth, a molecular diagnosis is never found. So this diagram illustrates the 2 domains in the Beckwith critical region. So imprinting center 1 regulates these 2 genes, IVF2 and H19, and imprinting center 2 regulates these genes. And again, disruption of these imprinting centers can, in any of these, can lead to, can result in Beckwith syndrome. Again, uniparental disomy, paternal UPD can also lead to methylation abnormalities and functional abnormalities in these genes, and Beckwith syndrome, as can variants in this in the CDKN1C gene. So this diagram just demonstrates the relative frequency of some of these different molecular mechanisms: loss of methylation on imprinting center 2, paternal UPD, gain of methylations on imprinting center 1, and then variants in the CDKN1C gene. This is another interesting case that we saw recently that was a set of monochorionic diamniotic twins that we saw in the mid-trimester. Twin A has an obvious omphalocele that you can see here, while twin B had a normal ventral wall and otherwise completely normal ultrasound. So this patient had an amniocentesis. We tapped both fetuses and they had normal microarrays, and we went on to do Beckwith testing. And twin A, the twin with the omphalocele, had a hypomethylation on imprinting center 2, consistent with Beckwith syndrome. And in fact, this is, as I said, responsible for 50% of cases. Twin B, which was structurally normal, had normal results. So clearly, this was a discordant Beckwith syndrome in this set of monozygotic twins. And so there has been, again, it is often surprising to patients when they have discordant genetic findings or discordant structural abnormalities, but it is well known that Beckwith syndrome is associated with twinning, and also has been associated with IVF or ART. And this was an interesting study that was reported a couple of years ago, where they looked at the association of Beckwith syndrome, again, with ART and twinning. So they had 301 prenatal samples that were tested for Beckwith syndrome. 40 of these were positive, or about 13.3%. And interestingly, in the cases that were positive for Beckwith syndrome, again, there were 40 of those, and 16 or 40% came from ART pregnancies. So when you compare that to the Beckwith negative samples, of which there were 261, only 3% came from ART pregnancies. So, again, ART was highly associated with Beckwith syndrome in this cohort. And they, again, they emphasized that 17% of the Beckwith cases occurred in twins, that 31% of the ART Beckwith syndrome cases were twins, while only 8% of the non-ART Beckwith cases were in twins. Most of the twins were monozygotic, discordant findings with hypomethylation of IC2 as the molecular cause of the Beckwith syndrome. And they concluded that there's clearly a relationship between methylation, twinning, and Beckwith-Wiedemann syndrome. So super interesting association and genetic finding in these pregnancies. So again, moving on to gastroschisis, which is really interesting in a very different way. This disorder doesn't really seem to be genetic, but rather has environmental influences in a very strong preponderance of cases that are seen in young women, mostly teenagers. Again, this is something that has been consistently reported, but is not well understood. So this was a study published just this year in the American Journal of Medical Genetics, where they looked at omphalocele and gastroschisis and other anomalies in those cases and compared them in a large cohort of patients seen in France. So this was well over 300,000 patients. All were over 21 weeks gestation, and they included cases that terminated, cases with stillbirths, as well as live births. And in this large cohort, they had 101 omphalocele cases and 75 gastroschisis cases. And some of the data on gastroschisis report that the prevalence is increasing. They actually did not find that in their cohort. And as expected, and as we talked about previously, there were associated anomalies in 74% of the omphalocele cases, while 77% of the gastroschisis cases were isolated and only 22% had associated anomalies. The omphaloceles, again, 74% had co-occurring anomalies, 44% of those were syndromic, and they were aneuploidies, Beckwith syndrome, OEIS, and pentalogy of Cantrell, and 30% had non-syndromic multiple congenital anomalies. So again, omphalocele highly associated with syndromic causes, as well as other more random multiple congenital anomalies. Gastroschisis, 5% were syndromic, including 2 cases of trisomy 21. So I think it is important, we talk about the fact that gastroschisis is not associated with aneuploidy, and although the risk of aneuploidy is low, reports of gastroschisis do consistently often report a percentage of trisomy 21 in the range of 1 to 2%, which in these young women is likely higher than background, and offering the option of testing for trisomy 21, whether it's diagnostic testing or cell-free DNA, is probably reasonable. There were also a couple of skeletal dysplasias, and amyoplasia congenita, again, is consistently associated with gastroschisis. 15% had non-syndromic other congenital anomalies, and many of these are GI abnormalities that are likely secondary to the gastroschisis itself. So gastroschisis itself, again, is a defect that is to the right of the umbilical cord. not covered by a membrane, usually isolated. And the risk factors include young maternal age, which is very strongly associated with gastroschisis. The odds ratio is in the range of 7 to 8, which is quite high. Low BMI is also independently associated with gastroschisis. Nulliparity, rural birth, cigarette and alcohol use, and some over-the-counter medications, such as acetaminophen and some of the allergy medications, have been associated with a low but sometimes significantly increased risk of gastroschisis. And again, in many studies, which seem to be localized to certain geographies, the rate seems to be increasing, but that is not true everywhere. Again, chromosome abnormalities are uncommon, but not completely unheard of. Occasional other anomalies that are syndromes that are associated with gastroschisis include amyoplasia and short limb dysplasias. And then some of these other organ systems are also sometimes reported to be involved with gastroschisis. The pathogenesis is therefore somewhat uncertain, but it is really of great interest in controversy. And the epidemiology, I think, implies that there is a significant environmental component, but the nature of that remains to be investigated. And this was an interesting study reported just a couple of years ago. And this group did a very comprehensive literature review of gastroschisis since 1950, essentially. So this is really the world's evidence regarding gastroschisis. And they pooled the data from large population-based samples of gastroschisis patients. And they looked at associated anomalies, chromosome abnormalities, clinical characteristics of the gastroschisis, and then the critical regions and genes that were seen to see if they could identify specific genes using this kind of a method that might be associated with gastroschisis. And they took these gene regions that were seen in these cases and used Gene Ontology Consortium in the Panther classification system, again, to look for associations that were of interest. So they included a total of over 18,000 gastroschisis cases. Not quite 18% had associated anomalies. A small percentage were syndromic. 3% overall, again, had chromosomal abnormalities, so something to bear in mind. But the large majority were associated but non-syndromic anomalies. And they found that there was overrepresentation of several gene clusters on different chromosomes, and genes in these regions were related to various biologic processes such as vessel integrity, angiogenesis, cell-cell or cell matrix adhesion, and other processes that could biologically be associated with a gastroschisis. So they felt that this supports a significant role of vascular disruption, thrombosis, and mesodermal deficiency in the pathogenesis of gastroschisis. So kind of interesting food for thought and a very large endeavor in a large series of cases. And then finally, I want to just mention some of the more complex ventral wall defects, including OEIS sequence, which again is omphalocele, cloacal exstrophy, imperforate anus, and spine abnormalities, pentalogy of Cantrell, which includes cardiac anomalies, pericardial defects, sternal defects, diaphragmatic defects, and abdominal wall defects. And then limb body wall complex, which includes exencephaly and encephalocele with facial clefts, thoraco and or abdominoschisis, and limb defects. So again, a fair amount of overlap of these disorders. And, you know, thinking about ventral wall defects in association with spinal defects, it is thought that ventral wall defects or many of these are caused by abnormalities of embryo folding at 3 to 4 weeks of gestation. So this is a cross-sectional diagram showing how that works. The embryo folds ventrally, to develop the ventral wall and develop the abdominal cavity. And then the neural tube is folding at the same time, leading to the development of the spinal cord. And one could imagine that abnormalities in this folding process could lead to both spinal defects as well as ventral wall defects. And I'm not really going to talk about this more, except to say that abnormalities likely seem to occur due to a combination of both genetic and environmental factors. So we're not ventral wall defects like spinal cord defects can be associated with genetic syndromes, but generally these complex anomalies are probably more complex and multifactorial developmental aberrations. And this is a graph kind of from a paper discussing the overlap of these complex anomalies. And D here stands for diagnostic criteria. C are things that are commonly seen, and the R are rarer, seen only in case reports. And basically, the point is that many of the diagnostic criteria overlap these three different disorders, as do many of the other features that are commonly seen. So I think, at the end of the day, there are associations in the development of these disorders that clearly overlap, and there is much still to be learned about how these conditions how they are caused. So to summarize, omphalocele and gastroschisis, the common ventral wall defects, are clearly very different, both in the underlying genetics, the associated anomalies, as well as the associated risk factors and outcomes. Omphalocele almost always associated with syndromes, genetic or structural abnormalities, and important to do an evaluation for aneuploidy and copy number variants, as well as Beckwith syndrome at a minimum. Gastroschisis is uncommonly associated with aneuploidy, but again, although it's quite a small risk, testing should be offered. Really, aneuploidy testing of some sort should be offered to all pregnant women. So this is not really different, but I think it should be mentioned that there is a small risk for aneuploidy. And complex ventral wall defects seem to be interrelated with each other and are likely multifactorial. So thank you very much. And I look forward to the second half of the presentation.
Hello, I'm April Adams. I'm an assistant professor at Baylor College of Medicine. Today, I'm going to be talking about some of the key counseling points when the diagnosis of omphalocele is made. This information will come from a review published as a part of the prenatal diagnosis series, What to Tell Prospective Parents, regarding the diagnosis of various fetal anomalies. I have no financial relationships to disclose. The objectives for today are to review the essential points for counseling when the diagnosis of fetal omphalocele is made, including when and how omphalocele can be diagnosed, the risk of genetic or multiple malformation syndromes, expected pregnancy complications, postnatal considerations, and short and long-term prognosis. An omphalocele is a congenital midline defect in the ventral abdominal wall, characterized by absent fascia, abdominal muscles, and skin, and the defect allows the herniation of abdominal contents. It results from an error in the process of body folding in early pregnancy at around 3 to 4 weeks, but should not be confused with physiologic gut herniation that resolves at about 12 to 14 weeks. It is one of the most common types of abdominal wall defects. The incidence ranges from 1 in 1,100 to 1 in 3,000 pregnancies. And the incidence in live births goes down a bit, secondary to some pregnancy loss, and is 1 in 4,000 to 1 in 5,000 live births. An Omphalocele can be diagnosed prenatally with the use of ultrasound as early as 12 weeks gestation. However, the sensitivity of prenatal ultrasound does vary from about 25 to 95%, and that depends on gestational age, maternal body habitus, and the expertise of the center performing the ultrasound. The most common time period for the diagnosis of Omphalocele is in the second trimester, with sensitivities ranging from 50 to 95%. The next most common time would be the first trimester after 12 weeks, and then less commonly in the third trimester. The key ultrasound findings when making the diagnosis of Omphalocele are a midline abdominal wall defect enclosed by a membrane, as seen here. The cord insertion can be visualized at the base of the defect and confirmed with color Doppler. Inside of the sac, you will see bowel, which can be identified with peristalsis, and there may also be liver inside of the sac as well, which can be confirmed with using color Doppler to identify the hepatic vessels. There's not a consensus for specific categories of Omphalocele. However, they can be generally grouped into small, less than 5 centimeters, giant, greater than or equal to 5 centimeters, or with greater than 75% of the liver in the sac, and rupture Omphalocele. Associated anomalies are commonly seen with Omphalocele, and can be seen in up to 25 to 97% of cases, although 20 to 40% of these anomalies may not be diagnosed until after birth. And some of that is due to anomalies that don't develop until later in the third trimester, such as gastrointestinal obstructions or bowel atresia, which may not be identified earlier. The most common associated anomalies are congenital heart defects, such as tetralogy of Fallot or dextrocardia, gastrointestinal anomalies such as intestinal malrotation or atresia or anal rectal malformations, and genitourinary anomalies such as renal agenesis or polycystic kidneys. And it should also be noted that even in the setting of a normal karyotype, at least 50% of fetuses will have an associated anatomic abnormality. So given this common association with structural anomalies, there's also an increased risk of genetic or multiple malformation syndromes. And actually, a small Omphalocele are more likely to be associated with an abnormal karyotype, but if structural anomalies are present, there's a 30 to 70% chance that there will be a chromosomal or multiple malformation syndrome. The most common genetic and multiple malformation syndromes are trisomy 13, 18, 21, Beckwith-Wiedemann syndrome, and pentalogy of Cantrell. There are also many, many other single gene disorders associated with Omphalocele. A short list here is Charge syndrome, Cornelia-de-Lange, Friends, Pallister-Killian syndrome, and Denai-Barrow. And so, given the associated anomalies, the risk for genetic syndrome, genetic counseling is really recommended in all cases of Omphalocele. And then patients should also be offered diagnostic testing via amniocentesis or chorionic villus sampling. Chromosomal microarray is the first-line testing option, given that it will screen for common aneuploidies as well as clinically significant copy number variants. However, if there's a high suspicion for a common aneuploidy, traditional karyotyping can be used as a first test. Also, screening with cell-free fetal DNA or rapid aneuploidy testing may be useful as well to evaluate for common aneuploidies. However, in the instance of cell-free fetal DNA or rapid aneuploidy testing. Postnatal follow-up would be recommended to evaluate for any clinically significant translocations that may impact our recurrence risk. The other thing that should be noted is that for conditions like Beckwith-Wiedemann syndrome, which is associated with up to 25% of omphalocele cases, the inheritance mechanisms can be quite complex, and so may not be picked up with just a microarray, and may require multi-tiered testing with a microarray, methylation testing, and sequencing. So in the case of a small bowel containing only omphalocele with a normal microarray and carrier type, consideration for Beckwith-Wiedemann syndrome and further testing strategies will be important. Also, in cases in which the microarray and our carrier type are normal, exome sequencing may also be useful in identifying single gene disorders. As far as the recurrence risk, it really depends on the presence of a genetic etiology. And in cases of an isolated omphalocele, when with otherwise normal testing, the recurrence risk can be estimated to be less than 1%. So pregnancy complications with omphalocele include fetal growth restriction in about a third of cases, as well as premature rupture of membrane, which is also secondary to polyhydramnios, which is very common. Ascites is also a frequent finding in cases of omphalocele. Preterm birth occurs in up to 65%. However, it's usually an iatrogenic preterm birth secondary to preterm premature rupture of membranes, non-reassuring fetal testing, or things like that. And the mean age of deliveries reported in the literature for omphalocele ranges from about 36 to 38 weeks. Intrauterine fetal demise is also something that should be considered in cases of omphalocele, as it can be seen in up to 20% of non-isolated cases or cases with genetic syndromes. And delivery should really be based on obstetric indications. However, in the case of a giant omphalocele, there may be concern for abdominal dystocia, and so cesarean delivery may be considered in those cases. In this box, there are just some general recommendations for the management of omphalocele. Doing a detailed anatomy survey to evaluate for associated anomalies, as that's very frequent in cases of omphalocele, as well as considering a fetal echocardiogram if that's available, as congenital heart defects are one of the most common associated anomalies. Offering genetic counseling and diagnostic testing to patients as well. And then the gold standard for diagnosis of omphalocele is an ultrasound. However, there may be cases in which an MRI, if available, may help evaluate for lung volumes and risk for pulmonary hyperplasia, especially in cases of giant omphalocele. Also looking at serial growth evaluations given the risk of fetal growth restriction, antenatal testing starting about 32 weeks, secondary to the increase for risk for fetal demise, and then trying to have delivery as close to term as possible, and delivering early based on obstetric indications, not solely the omphalocele, given the increased morbidity that prematurity will add to these infants that will already have a complex postnatal course. And then, of course, having a multidisciplinary team to plan out the pre and postnatal course for these infants. So in the postnatal period, infants with omphalocele will need ICU admission. And the pediatric surgery team will guide treatment based on their gestational age, the size of the omphalocele, and any associated anomalies. Primary closure may be feasible in some cases, but oftentimes a stage closure is needed. And the size of the omphalocele, the length of the staging process to close the abdominal wall defect, associated anomalies and syndromes varies widely with each omphalocele case, and therefore the hospital stay may range have a great range as well. Even in the setting of an isolated omphalocele that has a straightforward closure, most infants will still require some period of mechanical ventilation and a feeding tube. So the perinatal mortality in case of omphalocele really depends on the presence of genetic abnormalities, structural abnormalities, and the size of the omphalocele, the complexity of the postnatal procedures. But in the case of a small isolated omphalocele, the 1-year survival rate is approximately 90%. And in comparison to giant omphalocele with associated anomalies, the mortality rate can reach 100%. And so indicators for poor prognosis outside of associated anomalies and giant omphalocele are pulmonary hypoplasia, pulmonary hypertension leading to respiratory failure, prematurity, cardiac anomalies, and ruptured omphalocele. And in the case of ruptured omphalocele, one of the biggest concerns and one of the biggest causes of morbidity and mortality is related to sepsis, which can result in a mortality rate greater than 50%. The long-term prognosis for omphalocele also, like everything, varies with the size, with the associated anomalies, and genetic diagnosis, and with the postnatal surgical course. And so long-term studies in this very heterogeneous group are lacking. But in the case of an isolated omphalocele, the growth and physical growth and neurodevelopment has been shown to be normal at age 2. But keeping in mind that with giant omphaloceles, there may be a greater risk of neurodevelopmental and motor delay. Some of that may be associated to needing more surgical intervention and prolonged hospitalization. And all children, no matter the size of the defect or associated anomalies, are at risk for feeding difficulties, failure to thrive, clinically significant GERD, asthma, and recurrent pulmonary infections. So in summary, an omphalocele can be readily detected in the first and second trimester with ultrasound, but that most commonly is done in the second trimester. After detection of an omphalocele, a detailed anatomy survey should be performed and prenatal diagnosis should be offered. Many omphaloceles have associated anomalies, and around 30% of cases are associated with a genetic syndrome or multiple malformation syndrome. The overall prognosis depends on the size of the omphalocele and the associated anomalies and syndromes. But in the case of an isolated omphalocele, there is a 90% survival rate and normal developmental outcomes at 2 years of life. Thank you.
Thank you so much, Dr. Norton and Dr. Adams, for this very comprehensive presentation and great insights into the association with genetic syndromes and genetic abnormalities in these commonly identified abdominal wall defects. We now have time for a few questions from the audience. As a reminder, please put your questions for the presenters in the Q&A function and use the thumbs up button to vote for the questions you like the most. If you have a comment or want to speak out loud, you can raise your hand via the raise your hand feature. And if we have time, we will unmute you and call your name to let you know that you can speak. We do have a few questions already in the Q&A function. The first one asks, would you consider, excuse me, they're being moved around based on popularity here. All right, the first one is, okay, I'm glad it's not just me. Would you consider whole exome or whole genome sequencing for isolated cases of omphalocele with a normal karyotype, CMA, and Beckwith-Wiedemann test? And I guess this question could be for both of you.
Well, I'd be very interested in what April has to say. I think I would definitely do Beckwith testing first. I think that is where the money is. And often, you know, it can be tricky then to go on and do more testing. I think, you know, there are many disorders that are reported to be associated with Beckwith syndrome. And for some of those, we probably know the genes and an exome might find them. So I think for, you know, for information seekers, it's not unreasonable to do. I mean, we do it because we can do it as part of a study, and but when, you know, if it's anyway, so I think it's reasonable to do, but it's definitely not the first or even the second test. So I don't know, April, what do you think?
Yeah, no, I definitely agree. I think, you know, with Beckwith-Wiedemann syndrome, there are going to be some findings that you won't necessarily see till a postnatal period. So I think in a case in which you just have a small isolated omphalocele, you've done all of this testing prenatally, you may want to be able to take a really good look at that infant postnatally to see, okay, are we going to be able to guide our testing a little bit better with a better phenotype at that point? Mm-hmm. So I think definitely if it's available, sure. But I think, you know, you may still diagnose Beckwith-Wiedemann syndrome in the postnatal period. So I wouldn't say you can definitively exclude it prenatally.
Thank you. In a similar vein, a person asks, in a fetus with isolated omphalocele, but the weight, length, etc., is not higher than the 50th percentile or so, is Beckwith-Wiedemann syndrome still a high likelihood? I guess what is the positive predictive value, or, you know, the utility of this particular?
Yeah. I mean, most genetic things, you know, they don't all have all the features, and Beckwith is no exception. And so although macrosomia is a cardinal feature, it's not by any means universal. So I would still do testing, and you're nodding, April, you would agree?
I agree, yeah.
Thank you. There was one question, Mary, which I think you answered previously in the chat, but not everyone maybe saw the response. Thank you for a great presentation. I'd like to know if trisomy 18 is the most common chromosomal abnormality in the abdominal wall defects. And I think they meant omphalocele rather than.
Yeah, it's definitely the most common with omphalocele. I think, you know, again, with gastroschisis, there's the occasional reported case of Down syndrome. But yeah, trisomy 18 and omphalocele is a well-known association. They can also have trisomy 13, but much less likely.
Thank you. Another question asks, specifically to Beckwith-Wiedemann syndrome with omphalocele, what percentage of those could be detected with prenatal testing, since the methylation defects are difficult to detect?
I want to give some questions to April, but this was sort of from my talk. I would say, you know, if you look at the postnatally, and again, Rachel, maybe you can weigh in, it's about 80%, I think. It's not so much that the methylation's hard to do, it's just there's so many different molecular mechanisms. There's probably some cases where there's other things going on. I mean, most molecular testing does not detect, for most disorders, doesn't detect 100%. And I'd say 80%, would you agree, April, something like that?
You mean postnatally? Yeah.
That's the postnatal number. In prenatal, it's probably similar.
Yeah, I think for the most recent I've seen is somewhere between, I think probably a little bit less. Like I think prenatally, but it might have to do with just the lower suspicion prenatally that maybe, you know, we're not testing as much.
And not doing as comprehensive, yeah, not necessarily. Depends where you send it probably too. Some labs really do everything and some might not do everything.
Dr. Adams, maybe we can give you the next question. There's a question about pulmonary hypoplasia and omphalocele, and maybe you can talk as you're answering that about the utility of prenatal imaging, specifically maybe MRI in predicting this respiratory insufficiency depending on the size?
Yeah, so with an omphalocele, specifically with giant omphalocele, so if there's a large amount of abdominal contents that are in the sac, causing a smaller chest, you can have result in pulmonary hypoplasia in those cases. And there have been some studies that have looked at using MRI to predict lung volumes. And overall, it's been shown that if you have a predicted to expected lung volume less than 50%, that it does show an increased risk for prolonged hospitalization and pulmonary complications. However, they haven't been able to tie that necessarily with mortality if there's an absence of pulmonary hypertension. So there's the jury's still out on the complete utility for MRI. So ultrasound is still the gold standard, but definitely may be useful in cases when you're concerned about the degree of pulmonary hypoplasia that may be present.
Thank you. Somebody was asking about what is known about the proportion of prenatally diagnosed omphalocele cases that are terminated, and maybe that they didn't ask this, but could this lead to some selection bias in what we see in the reported literature?
Yeah, I think it varies a lot from study to study. I don't have a number that you could say on average. In some studies, it can be as high as 50%. So it really depends on the population that you're sampling. And also if we're looking back at older studies, there may have been differences in types of interventions that were offered for associated anomalies and diagnostic testing, things like that. So I think we probably need a little more prospective data to really answer that question.
Thanks. There's a question about recommendation of mode of delivery for gastroschisis, but maybe you can also expand that to omphalocele and whether you guys have specific cutoff size values for mode of delivery in omphalocele. So maybe you can answer both gastroschisis.
Yeah, so in gastroschisis, oftentimes the delivery is via a C-section in order to protect the bowel. With omphalocele, with a giant omphalocele, the risk of the rupturing the membrane and injury, bowel injury is increased the larger the size is. And so in those cases, especially when there's a significant amount of liver involvement, C-section can be recommended. But in small isolated omphalocele cases, there hasn't been any evidence to show that outcomes are better with a C-section versus a vaginal delivery. So it really should be guided based on whatever the obstetric indications are in that case.
Just to weigh in, I mean, we deliver all of our gastroschises vaginally. And okay. I'm not sure if there are literature on bowel injury, but we did actually look across we did a study looking at gastroschisis outcomes a few years ago and looked across the UC sites. So some sites delivered everybody at 36 weeks by C-section, some induced and delivered everyone vaginally at 39 weeks. And the only thing that changed outcome was the patients delivered by C-section did worse. And if they delivered it before 37 weeks, they did worse. So yeah, it was kind of interesting. But in any case, I know different, there's a lot of places that many patients with any kind of anomaly end up with a C-section for surgical pediatric surgeon reasons, I think. But
and Mary, do you guys at UCSF have a certain cutoff size value for offering C-section in omphalocele cases?
We don't really have a number. When there's a lot of liver out and it's really big, I think we hem and haw and end up doing a C-section a lot of the time. But we're not so number oriented. I don't know. What do you guys do with gastroschises and omphalocele at your place?
Me?
Yeah.
Yeah, we it's a vaginal delivery for gastroschisis routinely. We don't perform C-sections for that. And for omphalocele, it kind of depends, but I would say we favor cesarean for most omphaloceles just because of the concern of the rupture. But it is an interesting movie. Yeah. There's one question about gestational age of Beckwith-Wiedemann screening, and is there a gestational age cutoff at which you would perform this test, or from what gestational age can this be done, given that it's, you know?
Yeah, well, I think the question, as it reads, has to do with methylation. And, you know, one of the challenges with doing genetic testing that involves looking at methylation is that chorionic villi are methylated differently than other tissues and then amniotic fluid. So for things that where methylation is important, a lot of laboratories aren't comfortable doing it on CVS, and I think the accuracy is not quite as clear. I mean, even though you can see these early, I think lots of patients end up getting an amnio instead, and there's not a concern based on gestational age of that. But that's the concern is really with doing it on villi. It might not be as accurate.
Thank you.
I know. April, do you have any?
Yeah, I agree. It's really the CVS issue more so than anything else.
Yeah.
And then one more question about gastroschisis and aneuploidy. I guess this was quite an interesting comment, Mary, that a lot of people are surprised. And the question is, should you make that routine or just offer it to the couple, or in terms of genetic testing in these cases?
Yeah, I mean, I will be honest. I have not routinely offered it. I think we all, you know, believe that and it's true that the rate of aneuploidy is low. But, you know, honestly, in preparing for this talk and going through all the literature, most of the series have, you know, a couple of cases of trisomy 21 that end up meaning there's, you know, a 1 or 1% risk or 2% risk. And these are mostly, remember, gastroschisis is mostly in teenagers, right? So this is, you know, a population that's at very low risk for aneuploidy. So I guess I would say, really, I think these are not studies designed to look for aneuploidy so much. That the size of any of them is limited for something that's that is relatively rare in the population. But, you know, every patient should be offered the option to have aneuploidy screening at the very least with NIPT or diagnostic testing. So I think, you know, it's reasonable to offer it with the caveat that the risk is low. The chance of finding something is small, but not zero, and it may be slightly increased. And I have to say, that's not what I've done in the past, but I think it's based on the literature. I think it's not unreasonable to do that.
Thanks. And then we'll have just Dr. Adams just answer the last question really quickly because we need to wrap up. But just really briefly, information about associated anomalies or genetic syndromes with giant omphalocele versus maybe not a giant omphalocele. Is there an association between size and genetic aberrations?
Yeah, so karyotypic abnormalities are more common in small omphaloceles. However, you still have still an increased risk for chromosome abnormality or genetic syndrome with a large omphalocele as well. And as far as the incidence of associated anomalies, even in the setting of a normal karyotype or normal chromosomes, about 50% of cases will still have associated anomalies. So no matter the size of an omphalocele, genetic testing and a search for associated anomalies should be done regardless.
Thanks. And it looks like there's one last question. Sorry, this is of interest. Maybe this will be for you, Mary, because you offer vaginal delivery. Do you use sort of the way with complex gastroschisis or something about, you know, the way the bowel looks prenatally, would that alter your recommendation for a vaginal delivery?
No, not how the bowel looks, but what if there's other organs that are also, you know, if there's liver out, which can sometimes happen, or other organs, then potentially, but not matted, you know, ugly looking bowel.
Well, thank you so much, everyone. This was a fascinating discussion and great presentations. This concludes the second session of the ISPD virtual education series. I want to thank everyone for joining us today and give a special thank you to our speakers, Dr. Mary Norton and Dr. April Adams. The presentation was recorded, will be available on the ISPD website within 1 week. Certificates of attendance for last month's webinar and today's will be sent out from the ISPD within 10 days. The virtual education series will resume in September, and please, please, please be sure to visit the ISPD website to learn more about the upcoming International Conference on Prenatal Diagnosis and Therapy to be held virtually June 6th through the 8th, 2021. Thank you, everyone. Have a good day or a good night, depending on where you are. So long.